Good afternoon, everyone. We'll just wait for a few more of our attendees to sign on before we start. Okay, we'll get going. Thank you very much for joining us this afternoon for the last of our winter webinar series of 2022. Today we've got Dr. Lucy Meehan, one of our equine radiologists here at VetCT, who will be presenting on proximal suspensory desmopathy, does imaging alter treatment and prognosis. The webinar should last around 40 minutes, and there'll be plenty of time for questions and answers and any discussion that you wish to have at the end. Can I just ask you to pop any questions that you have as we go in the question and answer box at the bottom of your screen, not in the chat, if that's okay. And then at the end of the session, we'll go over those and hopefully have some good discussions. So I hope you enjoy and sit back and relax and see you soon.
Good afternoon, everyone. Welcome to our final winter webinar for this year. If you haven't been able to access the previous webinars, there are links available that Charlotte should be able to send you with the recording of this webinar if you're interested in the previous webinars. Today's topic is proximal suspensory desmopathy. Does imaging affect treatment and prognosis? So, the reason behind choosing this topic was that there's an awful lot of information out about proximal suspensory desmopathy. It's something that we really commonly see, and there's a lot of different opinions about imaging and what the imaging should tell us, and obviously then how that affects our treatment. I'm going to divide the webinar into two parts. The first part, which is a longer part, is going to discuss the imaging and actually, what practical imaging we have available. Then I've just got a couple of cases that I found interesting over the last couple of years that have presented a bit of conundrum from a treatment point of view to myself. And these are cases that one I saw clinically and blocked myself, as well as having read the images, and the other is one that I've been involved in discussions following the imaging part of the workup. So I'm going to start by just having a think about what proximal suspensory desmopathy actually is. It's a common thing, certainly both clinically and when I'm doing teleradiology. I see an awful lot of cases that are blocking to the proximal metatarsal region. We see it often in horses that are lame on a soft surface, or in horses that are performing poorly. So horses that have a lack of impulsion, poor jumping performance, struggling with collection, struggling with canter, and struggling with collected small circles. We often see it in horses that are reluctant to work and reluctant to go forward. And I know this is all really non-specific, but faced with the realities of a poor performance workup, it is something that does spring to mind. Some of these horses will have behavioural changes, so certainly there is reports of horses bolting that have a suspensory desmopathy, and there is also reports of bucking, resistance to saddling, and all these things that we see very commonly in a poor performance workup. Oftentimes these horses are flexion positive, and I think that's a really important thing to note. Certainly historically, we all thought that positive flexion was more related to hock pain and bone pain, but actually most of these horses, I think about 70 or 80% of these horses will be positive to flexion as well. So certainly it's something that when I'm doing a lameness workup, I'm looking at the horse trot, I'm doing flexions. It doesn't rule, a positive flexion test does not rule out these horses having proximal suspensory desmopathy. So once we're sort of presented with our horse and we're wondering about the proximal suspensory region, what do we need to be thinking about? Well, from an anatomy point of view, the proximal suspensory ligament arises from the palmar aspect of the third metatarsal bone. Sorry, the reason I'm chuckling to myself is that actually there's no such thing as the proximal suspensory ligament. It's desmopathy of the proximal aspect of the suspensory ligament that we're discussing. So the suspensory ligament itself arises from the palmar aspect of the third metatarsal bone. There is actually a more proximal accessory portion of the suspensory ligament as well, which arises from the palmar or plantar aspect of the fourth tarsal bone. And this comes in to the lateral aspect of the suspensory ligament and blends in at the origin. When we think about how the suspensory ligament is positioned on the third metatarsal bone, and this is important for imaging, it's actually quite laterally positioned. So this is a right hind lateral, this is a lateral splint bone here, this the fourth metatarsal bone. This is the second metatarsal bone here. And you can see our suspensory ligament is almost triangular in cross section. And we've got a larger lateral lobe and a smaller medial lobe. We've got this little divot here, which is just the separation between the lobes. And that can be mistaken for a lesion, this dorsal divot, certainly when we're doing ultrasonography. And as we go further distally, scanning down the body, just be careful that when we're scanning the distal portion where it bifurcates into the two suspensory branches, that we don't mistake that for a lesion as well. So if we think about this, this slide is a little bit odd because we go proximal on the right down to distal on the left. So this is a cross section at the level of the first and second tarsal bone, so at the level just above the proximal, so just above the tarsal metatarsal joint. And this is our accessory ligament of our suspensory ligament just here, arising from the fourth metatarsal bone. Here we're just distal, so about a centimetre distal to the tarsal metatarsal joint, and we can see this is our suspensory ligament starting to originate from the back of the third metatarsal bone, the plantar aspect of the third metatarsal bone. And as we go further distally, it becomes larger till we get to probably about 4 or 5 centimetres distal to the tarsal metatarsal bone here, where we have our very familiar sort of cross-sectional triangular shape. We do have these muscle and fat bundles within the middle of the suspensory ligament here and here. These become more prominent, sort of about 2 or 3 centimetres distal to the tarsal metatarsal joint. They're not entirely fully formed just at the origin here. So if we think about, so we've thought about our anatomy, what are we going to do next? Well, if we've got this horse that's either poorly performing or has a hind limb lameness, we may well put in a deep branch lateral plantar nerve block. Now, certainly, that's a block that we use very, very regularly clinically. It's possibly one of my least favourite blocks to put in, but the reality is it's probably one of the more frequent blocks that we do. So I think it's a block certainly 10 years ago. I would put in, if a horse is positive, it's got suspensory desmopathy, send it down the road to the surgeons, bish bash bosh, job done, and time for a cup of tea. Certainly now I'm a little bit more reticent when I'm doing my deep branch lateral plantar nerve block to really say that that is specific to the suspensory apparatus. My take on the deep branch lateral plantar nerve block, I'm aware this is out with the remit of the webinar, but I just really do want to highlight this. There is actually quite a lot of potential for analgesia of unintended structures. So if we think about when we're putting our deep branch in, the deep branch of the lateral plantar nerve is actually very, very close geographically to the lateral plantar nerve. So when we're putting 2 or 3 mil of local anesthetic in the region of that, it's likely to diffuse and anesthetize the entire lateral plantar nerve. Similarly, there is potential that we could infiltrate the tarsal sheath and the tarsal metatarsal joint. So I really do want to highlight that systematic blocking of these horses is essential to localize the lameness or the pain to the proximal metatarsal region. We know a certain number of horses that have a deep branch lateral plantar nerve block will have some desensitization of the skin in the distal portion of the limb. That was shown nicely by Dyson Nettell. And we also know that some of these horses will have desensitization of the tarsal metatarsal joint. So my protocol, if I'm blocking a horse that I think has a suspensory ligament or a proximal metatarsal pain, I would start by doing a low 4-point block, at least the lateral portion of, because we're probably going to take out the lateral plantar nerve further proximally. So I'd start by blocking the lateral portion of a low 4-point. I would then proceed and do my deep branch, and then on a separate occasion, and I appreciate this is the luxury of being hospital-based, I would then go back either the following day or later the same day, depending on the timings, and block the tarsal metatarsal joint as a separate entity. I think, we all have these horses where it's a one block one day, you're only going to get one in, so you go for the most likely. It's an 8-year-old warm blood, poor performance, we're going to stick a deep branch in. But I think we just have to be very, very mindful that is, we are possibly not as specific as we think we might be with that block. So it's a great block, it's a very useful block, but I think we just have to be aware that it can mislead us as well. This slide, I know we've seen this already, but I want to use it to illustrate something different. So in this case, we put blue dye into the tarsal metatarsal joint, and then we put red dye, 2 mils of red dye, where we would do a deep branch lateral plantar nerve block. The limb was then frozen and sectioned. And I think what I really want to show is the proximity of the dye columns to the suspensory ligament. So the suspensory ligament is highlighted in black here. You can see this is our deep branch, and you can see that our red dye has spread quite markedly. And you can see that our blue dye is also fairly close to the proximal aspect of the suspensory ligament. And I think that just highlights the degree of cross-reaction we have between the tarsal metatarsal joint block and the deep branch of the lateral plantar nerve block. And certainly it's something that I like to bear in mind when I'm interpreting these blocks. I tend to, and this is just my clinical practice, I tend to put 2 mils in at the deep branch of the lateral plantar nerve, and I tend to try and trot the horse at 5 and 10 minutes and assess response to that. With my TMT block, I put between 4 and 5 mils in, to be honest, until I get back pressure. And then I would trot the horse again at 5 and 10 minutes and assess improvement, just to try and be as specific as possible. But I think we're all aware we can't be massively specific with these blocks. So once we've got our horse that's lame, that we've localized the lameness to the proximal metatarsal region, why do we bother to image them? Now, a cleverer person than me, Dr. Rachel Murray, when I was speaking to her about this webinar last week, we were talking about types of proximal metatarsal pain. And her interpretation I thought was really nice and simple. There's essentially 4 different things that can go on in this region. We get suspensory ligament damage only, so damage to the proximal aspect of the suspensory ligament. We get disease that involves both the suspensory ligament and the bone ligament interface, so the enthesis of the bone and the ligament onto the bone. And we see this relatively commonly. We get some fairly interesting osseous reactions at the interface between the bone and the ligament. Occasionally we get horses that have bone injury only, and certainly in my experience we see this more commonly in the forelimb, but we do see it in the hind limb as well, where the ligament looks fine, but we have got injury to the bone itself at the insertion, or the origin, sorry. And then fourthly, we do see a subset of these horses that block to the proximal metatarsal region have pathology that's unrelated to the suspensory ligament or the bone interface. And certainly as we go through the webinar today, we will see that there's a growing body of evidence that some of these horses actually don't have pathology related to that region. So what we're trying to do with our imaging is to determine which is the primary structure involved. And I know I'm going to keep coming back to this, but we do really need to bear in mind that accurate diagnosis is key to our targeted treatment. And if we don't have an accurate diagnosis, obviously our treatment outcomes are going to be affected. So we're going to have a quick run through the imaging modalities that we use and how and what type of pain or what type of pathology we can assess using that. And then we're going to discuss a couple of cases. So just before we do that, I just want to touch on treatment outcomes. And I think the other important thing to bear in mind when we're talking about proximal suspensory desmopathy and certainly treatment options, actually there's not that much evidence about treatment outcomes. There was a nice paper about shockwave that came out in the early 2000s, and then another one that was a long-term follow-up that essentially showed that most horses that have shockwave therapy will improve transiently, but often the lameness will recur within 12 to 18 months. There was a nice large-scale study at the Animal Health Trust that looked at 155 horses that had had neurectomy and fasciotomy for hind limb proximal suspensory desmopathy. And what this paper shown was actually there's a significantly different outcome for horses with proximal suspensory desmopathy alone compared to horses that have proximal suspensory desmopathy in combination with other pathology. So that again highlights how important it is for us to be sure of our diagnosis. About 80% of horses with proximal suspensory desmopathy alone had a successful outcome following neurectomy and fasciotomy. So it's not 100%, 1 in 5 still don't do, but it is probably as good a prognosis as we're going to get in equine. Unfortunately, that prognosis decreased to 45% of horses with concurrent pathology. So that concurrent pathology varied between forelimb lameness, other causes of hind limb lameness, back pain, and sacroiliac joint pain. And actually, the sacroiliac joint pain group had a trend towards a worse outcome. So we do know that any concurrent pathology is going to detrimentally affect our prognosis. There are some other studies that reported a variable success rate, but those studies were dealing with much lower numbers. The reason I just wanted to highlight that is obviously we still recommend neurectomy and fasciotomy as a treatment for proximal suspensory desmopathy, but certainly in my clinical practice, I am less positive than maybe I was 10 years ago about the outcomes in these horses. So we'll go on to the imaging. So if we're going to start by looking at our horse side imaging modalities. So I would always take radiographs of these horses. I would always take a minimum of 4 views. And I always want to see quite a bit of the distal, the proximal metatarsus here. So I do tend to center my Hock films quite a bit further distally. So you can see I don't have the top of the calcaneus here. And that's because I'm primarily, certainly in a horse that's blocking positively to the proximal metatarsal region, I'm primarily interested in this region here. This horse was a 12-year-old warm blood mare that had a history of a 6 out of 10 hind limb lameness. This horse blocked 50% to a deep branch lateral plantar nerve and then fully to a tibial and peroneal nerve block. And I think we can all agree there is some fairly marked sclerosis of the proximal axial aspect of the third metatarsal bone here. And actually you can see this, and this is quite a neat thing when you see it. You can see some endosteal reaction here on the lateromedial view as well. We don't always see that, but certainly if I'm seeing this pattern of sclerosis here in this region, I go looking for this pattern for whether or not I've got any endosteal reaction here as well. It can be quite difficult to see that because obviously we've got the splint bones superimposed over that region on our radiographs, but certainly it's worth looking for if you are radiographing these horses. I would always take a minimum of 4 views because I like to have as much information as possible. Certainly, there is a school of thought that we just need to take a DP and a lateromedial or a DP only, and certainly in cost-limited cases, that can be an acceptable thing to do. My only word of caution with that is certainly I've been caught out doing that, missing distal intertarsal joint lesions that haven't been visible on the DP view. I think there is a little bit of distal intertarsal joint narrowing in this horse, but I think it's of lesser concern. When we're thinking about the radiographic changes associated with the third metatarsal bone, a recent study, a really nice study that's just come out of Colorado, showed that the presence or absence of sclerosis didn't have any association, or radiographic changes didn't have any association between the presence or severity of proximal suspensory desmopathy, but that was purely looking at ligament only change, so not assessing the ligament bone interface. There was a significant association between the presence of radiographic changes and plantar cortical changes of the third metatarsal bone, so that's looking at bone ligament interface and bone injury only. And their conclusions from this study was that radiographic changes do not reliably predict the presence or absence of ligamentous change, but they are associated with osseous change of the proximal third metatarsal bone. And they did comment that they didn't have any information as to how that affected clinical outcomes. But I think it is interesting just to think that we all look at those sclerotic areas and think, could there be some proximal suspensory desmopathy? But actually, do we need to be thinking more in the terms of actually, is there a bone ligament interface injury in these horses? And if we're thinking, is there a bone ligament interface injury, should we be doing further imaging to investigate that before we proceed to a neurectomy fasciotomy? These are all questions I have myself. I don't have the answers to these questions. I just thought I would pose that as something to make people's brains tick over. Ultrasound, I mean, this is the thing that we all do. Immediately we have a horse that blocks the proximal metatarsal region, or if we've got high index of suspicion, we sometimes do it before we do the blocking, just so we don't end up with gas in our way to image these. So it's a fairly commonly used imaging modality. It's available patient side. I mean, most of us in ambulatory practice would have an ultrasound scanner in our car. You block the horse, or you suspect proximal suspensory desmopathy, maybe scan the horse before blocking. I think it's really important, though, to bear in mind that actually there are some limitations of ultrasonography, and certainly there is a reasonable body of evidence now that there is fairly high intraoperative variability, certainly with acquisition and interpretation of these images. What are we assessing when we're doing ultrasonography? Well, we're assessing the ligament and the plantar aspect of the ligament bone interface. So we can't assess the whole bone ligament interface, we can't assess the endosteal surface of the bone, but we are able to assess the plantar and periosteal surface of the bone. We do know that there's quite a lot of artifacts when we're scanning this region, and we'll talk about those in a slide in a second. And another thing that can cause issues when we're interpreting these lesions is actually we have these fat muscle bundles within the ligament, and those can appear as hypoechoic areas within the ligament, and we just need to be careful we don't overinterpret that. I'm not going to talk long about ultrasonographic technique because I'm sure all of you are seasoned ultrasonographers. Just to say that obviously we use the plantar remedial approach for our transverse images, and this gives us really nice definition of the superficial digital flex tendon, deep digital flex tendon, a little bit of accessory ligament here, and then this is our suspensory ligament just in this corner here, lateral splint bone, and the back of the cannon bone here. And you can see we're not assessing the whole of the suspensory ligament, so we get better visualization of the lateral lobe, but we are losing some of the medial lobe. I always use a standoff when I'm acquiring these images because I think that is massively helpful in getting a better area of contact, but I know that's a little bit controversial. Certainly I usually have to go and hunt down the standoff when I'm scanning. So I think that we just have to be aware that we're not able to assess the whole of the ligament, and there is a body of evidence that suggests that we are going to miss parts of the medial aspect of the ligament, and also that we need to take care when we are assessing cross-sectional area using this technique, because actually between studies this may not be repeatable, and certainly between operators this may not be repeatable. As we go further distally, we can come around a little bit further plantally on the limb, so superficial, deep, accessory ligament of the deep here, and then our suspensory ligament becomes a lot more rounded. We get this nice gap between the plantar aspect of the third metatarsal bone and the dorsal aspect of the suspensory ligament. I briefly mentioned artifacts in our previous slide, and I just want to reiterate that ultrasound machines are built to understand straight lines. So anything that has a curved edge causes an artifact. So you can see in this image, I'm sorry, it's coming really pixelated, but we have a dark line here from the curved edge of our deep digital flex tendon. We have dark lines coming down here from the curved edges of our lateral plantar metatarsal vessel. We've got some through transmission artifacts. We've got some increased echogenicity artifactually within this tissue here, just because the ultrasound machine can't understand that we've got hypoechogenicity here. And we've also got what we call off-incidence artifact. Now, this can be really, really helpful, but when our ultrasound beam isn't at 90 degrees to our structure being imaged, we don't get, 90 degrees to the collagen fibers being imaged, the reflection doesn't come back to the ultrasound probe. So we get this artifactually black area within our ligament. Now, this can be really, really helpful, and we'll come on to why that is shortly. But just to bear in mind that not only are we trying to ultrasound through 3 different structures on top of the proximal, top of the suspensory ligament, we're also trying to battle with these artifacts as well. So it just sort of highlights why ultrasonography of this area is a bit more challenging than perhaps we think it is. And also there's the intra-operator variability of interpretation. Now, I think everybody would agree that there is fairly marked pathology in this poor horse's suspensory ligament. This is a 8-year-old national hunt horse that became lame after training and had a markedly swollen limb. Again, we've got superficial, deep check ligament somewhere in here. There isn't much of a check ligament. And then we can see we've got an enlarged suspensory ligament here, and we've got fairly marked hypoechogenicity of the entire dorsal portion of this ligament. Thinking about assessing the bone interface, so in this horse we had, so this is our in transverse, this is, in longitudinal, this is our plantar aspect of our 3rd metatarsal bone here, and we can see we've got these 2 well-defined osseous, well-defined hyperechogenic linear structures, which are consistent with osseous fragments. And we can see we've got total loss of fiber pattern in the dorsal part of the suspensory ligament here. So this horse had a suspensory ligament avulsion in the proximal portion of the hind limb and has very marked ultrasonographic abnormalities. This is a different horse. This is one from a high field MRI study, and this horse has bilaterally abnormal dorsal portions of the suspensory ligament on MRI, and it has some bone ligament interface disruption here and some endosteal reaction here. Interestingly, I think the suspensory ligament itself, ultrasonographically, there is some heterogeneity here within the very dorsal portion and on both sides. So some hypoechogenicity, but actually I think that the MRI picture with loss of the muscle and fat bundles and marked increased signal within the collagenous tissue here and marked enlargement here appears much, much worse to me than would be shown by the ultrasonography. So then we come to actually asking how accurate our ultrasonography is. So the high field MRI paper, which the images I've just used were taken, showed a sensitivity of 77% and a specificity of 33% for detection of disease. So for people like me whose brain doesn't work in sensitivity and specificity terms, the true sensitivity represents the true positive rate. So if you're seeing changes, it's probably real. But the specificity represents the true negative rate, and that is very low at 33%. So this really infers that there are many false positives diagnosed by ultrasound in a population of horses, many false negatives diagnosed by ultrasound in a population of horses. If you're seeing something that is probably there, but if you're not seeing anything, it maybe means that the changes are there, we're just not able to see them. There was another study that documented inter and intra-operator variability for longitudinal and transverse scans, and they found that actual variability was marked for all measurements of cross-sectional area, lateral medial width, apart from the dorsal palmar thickness in the longitudinal scan. So I think it just highlights that both inter-operator and intra-operator variability is quite high, and that measurements maybe aren't that helpful. There was a much more recent study which looked at cross-sectional area pre and post surgery, which compared to pre-surgery MRI, and they didn't find very much difference in cross-sectional area. But an earlier study by Schrammer et al. Really found that the size of the ligament was underestimated ultrasonographically. So I think it's just to bear in mind that there is a lot of factors affecting our ultrasound diagnosis, and also a lot of potential for error, a potential for variability between operators when we are scanning these limbs. So Ultrasonographic changes have been shown to be accurate compared to histopathology, which is always reassuring. There's a nice paper by Dyson Nettell in 2017 that looked at 19 horses with bilateral proximal suspensory desmopathy, diagnosed ultrasonographically, and then the horses went for histopath. They did find a relatively high proportion of horses had adhesions. This was more common in the horses that were lame post-surgery, and this is an image from the paper of a horse that had surgical treatment for proximal suspensory desmopathy, and you can see there's a complete loss of separation between the palmar aspect, the plantar aspect, dorsal aspect of the accessory ligament of the deep digital flex tendon, and the palmar plantar aspect of the suspensory ligament. So those could be predicted ultrasonographically. However, I certainly, in my hands, I'm nowhere near the ultrasonographer that Sue Dyson is, and I find those quite difficult to predict. However, it is useful to know that those do exist, and that they are predictive of disease. How do we improve our ultrasonography of these lesions? Well, I quite like this angle contrast ultrasound technique, which utilizes the fat and muscle bundles within the ligament to provide contrast between the collagenous portion of the ligament and the fat muscle bundles. So this is a flexed off incidence view. So this is our lateral splint bone here, our fourth metatarsal bone. This is the back of our third metatarsal bone, and this is our fourth metatarsal bone. The crosses mark the muscle and fat bundles, and then the black areas around that are the collagenous portion of the ligament. A far more beautiful picture of that is available in this paper by Denois. And you can see this is an on incidence, so with the probe perpendicular to the collagenous portion of the ligament, and an off incidence with the probe at 30 degrees approximately to the collagenous fibers. And you can see here, you can see here we've got, this is our suspensory ligament here and here, and you can see this sort of banana-shaped hyperechogenic area, and this corresponding one here are the muscle and fat bundles within the ligament, and then these peripheral darker regions are the collagenous portion of the ligament. I really like this technique because it really allows us to look at the whole ligament. It allows us to compare size of the ligament between right and left hind limbs, and it also allows us to look at the size and shape of the muscle and fat bundles. And I find that really, really useful when I'm assessing these. These images are from a clinical case that I saw actually whilst I was doing CPD in Eastern Europe. It was one of those where you go and do CPD and you're expected to block, treat and cure a horse within 15 minutes. This horse had some relatively marked hind limb lameness, left hind limb lameness for a period of time. I declined to block it because it was on box rest and it was bronching around the arena, so I didn't think that was a sensible thing to do. But we did ultrasound it. The horse had been blocked previously to the proximal metatarsal region. These are the flexed off incidence views, and you can see this is the lame leg, this is the non-lame leg. We've got quite a marked enlargement of the suspensory ligament here when we compare left and right. And what we've also got, which I think is really nice, we've got these banana-shaped muscle and fat bundles here are actually squashed and much more peripheral when we compare left and right. So this is the lateral on the left, this is the lateral on the right. You can see this fairly marked compression of the muscle and fat bundles, and this dorsal sagittal portion of the collagenous portion of the ligament is much, much thicker. And this to me is fairly consistent with a marked desmopathy of the ligament. And certainly I see this probably a couple of times a month in horses that I'm scanning that are relatively severely affected. So I think it's something that we do see, and it's something that can be useful. I try and do it on all horses now, just because then you get your eye on for what normal looks like. It doesn't take long after the scan. I tend to either just get them to flex the limb on the tip of their toe or put them in a Hickman block, and it is actually a very useful thing to do. I certainly find it helps me anyway. What do I do when I'm scanning these horses? I just wanted to say that I actually do scan the entire proximal suspensory, the entire suspensory ligament. So I go proximal, I scan down to the body, and also try and scan the branches. And this is our friend, the National Hunt horse from earlier that had the avulsion, and he's actually got quite a nasty medial branch injury that we can see ultrasonographically as well. Certainly in the forelimb more so than the hind limb, I find that suspensory body injuries can be relatively easily overlooked, and they tend to block in a very similar manner to a proximal injury. And certainly in my hands, those tend to have a poorer prognosis. So I would always try and scan the whole of the ligament, not just the sort of proximal 10 centimeters. I usually do weight-bearing scans in transverse and longitudinal planes, and then I usually do flexed on and off incidence scans, so the angle contrast technique that we were talking about earlier. A proportion of these horses will come in for scintigraphy. So certainly we do see a proportion of these poorly performing horses that come in for scintigraphy. I would say that in my hands, increased radiopharmaceutical uptake associated with the origin of the suspensory ligament is relatively uncommon. And we usually only see it in relatively severe cases. Certainly, I would say if there's increased radiopharmaceutical uptake present, it's likely to be significant and would point me in the direction of looking at the proximal metatarsal area. However, we do have a high percentage of false negatives. So I think we see increased radiopharmaceutical uptake in these horses that have bone ligament interface disorders or that have bone change on its own. I don't think, well, we don't see anything in horses that just have problems with the ligament. So certainly in my hands, increased radiopharmaceutical uptake on scintigraphy has associated with the worst prognosis. However, in the Dyson paper that looked at long-term outcomes following treatment, they didn't find a significant association. However, they make a comment in the discussion that there may have been a trend towards that, but they don't have sufficient numbers of horses that had scintigraphy. This is a very lovely, or was a very lovely Spanish riding horse. This is a soft tissue phase image. So we inject the radiopharmaceutical and pretty much immediately image the hind limbs. And I don't think that there's anything abnormal really. There's maybe a little bit of diffuse uptake in this right proximal metatarsal region, but certainly nothing that I would have called at the time. And then when we look at our bone phase images, we've got a really very focal region of radiopharmaceutical uptake in the region of the origin of the suspensory ligament on the right hind here, and that fits with the horse was right hind limb lame. On further imaging, he had sclerosis of that region on radiographs, and he had a fairly marked suspensory ligament injury on ultrasonography. So moving on to MRI, because that's something that we also do relatively frequently. It is a very widely available imaging modality, and standing MRI examination of this region is becoming more and more common, primarily because we know we can do it, and you know there's the expertise there to read these images now that maybe there wasn't when we very first started doing standing MRI. And also the standing MRI systems have markedly improved motion correction even when we compare to 10 years ago. So we are doing an increasing number of standing MRI studies of this region. There is also certainly some lovely papers coming out of Colorado where they do an awful lot of high field MRI of this region, and that does have certainly a faster acquisition time and less motion artifacts and better resolution. However, it's not really available in the UK and Europe, but certainly for our American friends, it maybe is a better way to go. So what evidence is there for use of MRI? Well, there's been a few papers recently, just in the interest of time, I'll just whistle through these. Love and Nettell maybe published the first study looking at 46 horses with proximal metatarsal pain, and only in 21 of these horses did they find significant abnormalities within the proximal proximal aspect of the suspensory ligament. In the other horses, they found distal tarsal lesions and also conditions. So 9 horses had conditions unrelated to proximal suspensory desmopathy. So these horses had lesions in the distal tarsal region. And in 12 of these horses, there actually was no significant pathology detected. And this is the paper that found a low specificity of ultrasonography when compared to MRI. The group from the Animal Health Trust published another paper in 2018 comparing MRI, gross postmortem, and histopathology. Interestingly, they only found abnormal signal in the collagenous portion of the ligament, so this black bit here. They only found that was abnormal in 2 out of 12 limbs, but they found abnormal signal in the muscle and fat bundles in 11 out of 12 of the limbs. So the muscle and fat bundles should be fairly bright white on this signal here. So this is the normal muscle and fat bundle in the lateral aspect of the limb. And this sort of murky grey, fairly ill-defined region here is the muscle and fat bundle in the medial lobe, which is fairly abnormal. Interestingly, enlargement of the ligament was only found in 4 out of 12 limbs, and that's one of the things we use ultrasonographically. So maybe that's another thought that our ultrasound possibly isn't as accurate as we think it is. Another lovely study that came out of Colorado showed that only about 50% of the limbs that blocked the proximal suspensory region had proximal suspensory desmopathy, and a high proportion of them had distal tarsal pathology, even either on its own or in correlation with proximal suspensory desmopathy, and they included the bone ligament interfaced in with the proximal suspensory changes, as far as I recall. What they also found was that there was a poor correlation between the grade of lameness and the severity of the MRI changes, and that actually most horses had changes in the distal tarsal joints. So they concluded that in horses that are blocking to the proximal metatarsal region, they would routinely assess both the proximal metatarsal region and the distal tarsal region, because there is a lot of cross over between the blocking pattern. So what is the advantage of doing MRI? Why would we do this over or as well as doing ultrasound and radiographs? Well, it shows us a lot more about osseous abnormalities, the origin of the suspensory ligament. So this is another of our high field images. This is fairly marked endosteal irregularity here at the origin of the suspensory ligament. It also shows us this increased signal within the collagenous portion of the ligament, which may correlate to hypointensity on ultrasound, but I'm not sure it always does. It shows us changes in signal intensity within the fat muscle bundles within the suspensory ligament. Now, we don't always see that. Well, I don't know that we can see that on ultrasound. We can see the ligament, the bundles themselves, and we can see changes in size and changes in shape, but I don't think we can see changes in composition of the ligament. And certainly the Dyson paper found that that was sort of the key, the most significant finding was changes in signal intensity in the fat and muscle bundles. It also shows a lot about the distal tarsal region. So these papers were commonly finding bone marrow edema in the distal tarsal bones. They were finding subtle osteoarthritis or less subtle osteoarthritis of the distal tarsal joints. They're finding subchondral bone defects in the distal tarsal joints and osseous cyst-like lesions. So I think it does really show us an awful lot more than ultrasound and radiography alone. Can we see the same thing on high field versus low field? So this is our high field image that we talked about earlier. This is a low field image with a similar degree of pathology. So we've got a loss of definition of the fat and muscle bundle within our medial lobe here. And we've got enlargement of the medial lobe of the ligament as well, to my eye. So I think that we can see similar changes on low field, but obviously they're not as precise and beautiful. This is an example of a low field case that I saw clinically. So this horse was fairly lame. This is a horse that had the x-rays that we talked about earlier, actually. So you can see this endosteal reaction here on the plantar aspect of the third metatarsal bone. Medially, we've got some fairly marked disruption of the bone ligament interface and the collagenous portion of the ligament here at the medial lobe. And you can see this continues further distally out with the insertional portion of the ligament. So when high field or low field MRI goes well, we get some very beautiful images and we can get some very nice diagnoses. Sometimes the reality is that it looks like that. We do sometimes get horses that just won't stand and horses that won't tolerate, and then we have to have a rethink. So when would I use MRI? Well, my technicians would like me to say never, but unfortunately it's something I find myself reaching for more and more. I tend to use it when we've got horses that have equivocal ultrasound or radiographic findings. So, and certainly if I've got a lameness that's disproportionate to those findings. So horses that are 3, 4 out of 10 lame and I've got very mild ultrasonographic findings, I probably would want to just whack those through the MRI and just see what we can see. Horses that have increased radiopharmaceutical uptake in that region on scintigraphy, I don't feel we can assess the bone ligament interface or what's going on in the bone adequately radiographically. So I would usually at least have a discussion with the client about MRI in those cases and really try and push them to MRI. Unfortunately, in the UK, the reality of this is sometimes that there just isn't budget to do scintigraphy, MRI, and then treatment. So sometimes it's a discussion, but sometimes it's not high on the priority list. And also, when the blocking is equivocal. So if we've got a horse that improves 50% to a TMT and 80% to a deep branch lateral plantar nerve, those are the horses where I'm like, I'm not sure what's causing the most of an issue. So that's when I might put those horses into MRI. I've just got a little slide about CT for completeness. Certainly it's not something that I would reach for proximal suspensory or proximal metatarsal investigations. There are some clinical reports of using CT in investigation of these changes. It's most useful for identification of new bone at the emphasis of the suspensory ligament. The contrast enhanced CT, so I've just put a contrast enhanced image in here. It's not been compared to MRI for diagnosis of proximal suspensory desmopathy. This is a contrast enhanced image, so you can see we've got fairly marked contrast in the medial plantar artery. There's anterarterial contrast. There's not really very much contrast within the suspensory ligament at this level, which is possibly normal if there's no hypervascularization. But what we find is that this vessel here causes some fairly marked streaking artifact when it's full of contrast, and actually it can interfere with assessment of the suspensory ligament. So it's not my first line. Certainly we do see an occasional case of proximal suspensory desmopathy on CT, but certainly it's not my first line of imaging. So to just summarize the images before we move on to the cases, I just want to reiterate that localizing the precise cause of lameness in the proximal metatarsal region is challenging. And I think if we're going to talk about treatment and prognosis, we have to acknowledge that actually diagnosing the problem can be a challenge, and we need to make sure we know what the problem is before we embark on a treatment program. Radiography and ultrasonography have limitations, so we know that the radiographic changes don't predict the presence or absence of proximal suspensory desmopathy, but they are better at assessing the bone ligament interface. Ultrasound can be challenging to interpret, and there's so much variation intra-operator, inter-operator, variation in the angles, variation in the conformation of the horse. So it can make it really difficult. I'm not saying that ultrasonography is useless by any stretch of the imagination. I think it's a very useful tool in our armory, but we just have to be careful that we're not, relying on it to the nth degree, because I think it can mislead us. I do really like the flexed off incidence technique, and certainly it's really proved a useful addition to my ultrasound examination of this area. Advanced imaging gives us more information. It gives us more information about what's happening with the distal tarsal joints. It gives us more information about what's happening with the bone ligament interface. I don't think necessarily it needs to happen in every case, but I think in these tricky, challenging cases where we're maybe not seeing, we maybe don't have a clear-cut picture, it can be very, very useful just to tease out what's going on. So I want to just talk, there's a couple of cases that I've been involved in that I just want to chat through, and I'd be very, very interested in anyone's comments. So if you want to pop a question in the question and answer box, Charlotte can pop up and ask me and relay your questions to me. So this is the first case. This is an 11-year-old warm-blood mare who had a relatively marked right hind limb lameness, 4 to 5 out of 10. Interestingly, she didn't present for lameness. She presented for resentment of saddling, reluctance to go forward, and bucking when the rider got on. She was negative to a low 4-point block. She had a positive response to a tarsal metatarsal joint 10 minutes post-block. So it was only a 50% improvement, but a 50% improvement to me is a significant improvement to a tarsal metatarsal joint. We let that wear off, looked at her a couple of the following morning, and she was positive to a deep branch lateral plantar nerve block. Okay, so far so good. Because there was a suspicion of back pain, and because of the booking behaviour and various involvements of other paraprofessionals, we decided to proceed to scintigraphy with this case, which was relatively boring, if I'm totally honest, apart from this area of increased radiopharmaceutical uptake just here, which corresponds with the origin of the right suspensory ligament. Radiographs, well, maybe I could say there's a little bit of sclerosis dorsolaterally here. Possibly with a retrospectoscope, I'm seeing that a little bit more than I was at the time. And then we've just got a tiny spur of bone just here on the dorsal aspect of the tarsal metatarsal joint. That could be enthesiopathy of the insertion of the dorsal tendons, or it could be relative to the tarsal metatarsal joint improvement. Ultrasonographically, we've got a little bit of irregularity and loss of fiber pattern here within the dorsal aspect of the ligament. I have to say, retrospectively, going back through these to prepare this presentation, I thought more of this than I did at the time. So whether that reflects the static images versus the dynamic imaging, or whether that reflects a different mindset on my part, I'm not sure. But certainly to me, this was not significant enough to be giving me the degree of lameness I was seeing on the ground. So there was a lot of pressure for this horse to get to dressage camp in the summer. So we initially medicated the tarsal metatarsal joint on the basis of the partial improvement, and the horse had 4 weeks of walking exercise, and there was no improvement either in the lameness or in the associated clinical signs. This horse then, there was a bit of a discussion about what we did next with this horse, whether or not we should have MRI'd it. Now we'll come on to that in the case reflection, but we went ahead because of budget restrictions. We did a right hind deep branch lateral plantar neurectomy and fasciotomy. Because of the bone ligament interface injury and because of the other perceived issues, the horse had 8 weeks of small paddock rest, and by small paddock I mean or loose box size, followed by 4 weeks of in-hand walking before reassessment. We trotted her up at this time, and there was very little improvement. For various reasons, the in-hand walking only continued for 2 weeks, and then we had ridden walking. And the initial presenting clinical signs, which was the roaching of the back, the bucking, did not improve at all. So the horse was actually turned away. 6 months post-surgery, we reassessed her, and there was no significant improvement in the lameness. So this horse has now gone to be in foal, which we can discuss the relative sensibility of that as well. So I always like to think about these cases when I've got the horse back in the stable, I've not got to talk to the owner, and I can actually just sit and think about them. So in my eyes, sort of, should I have made more of this increased radiopharmaceutical uptake on scintigraphy? Was that indicative of more of a bone ligament interface injury than I could see on ultrasonography? So perhaps I should have pushed harder for this horse to go to MRI. I think there was a component of TMT joint involvement with this horse. However, I think that should have resolved as much as it was going to with the TMT joint medication, perhaps. There was a perception of concurrent back pain. The horse didn't have any uptake scintigraphically, but radiographically there were some close spinous processes. And actually, with hindsight, that would have downgraded the prognosis for a full recovery anyway, based on the treatment plan that we had. And I don't know if the prognosis is worse in these horses with a bone ligament interface injury versus horses that have just a suspensory ligament desmopathy. In my hands, it is worse, but I probably don't see as many of these as other people. So I think my big question for myself with this horse is, would MRI have changed our treatment plan? Should I have MRI'd this horse at an earlier stage? The real limitation with this horse was financial. We weren't able to do scintigraphy, MRI, and surgery within the budget. So I think perhaps we should have maybe dropped the scintigraphy and perhaps done the MRI instead. But then if we hadn't had the scintigraphy, I wouldn't have known about the bone ligament, the bony component of the problem. So these are the things that there's no answer to these questions. I think it's just a useful thought process to think, actually, what would I have done differently, and was there more going on than I thought? Did anyone have any comments on that case? Nothing from Charlotte.
Yeah, nothing so far.
Okay, and you can say, what were you doing, really? So the second case I want to discuss is actually one I was involved in more of an imaging perspective rather than from a clinical perspective. This was a 6-year-old Irish sports horse gelding who was initially referred for a right hind limb lameness, relatively sort of mild to moderate, and was referred initially for nuclear scintigraphy. Now, this was performed at a different clinic, so I only have the selected images, but I think we can agree there is some radiopharmaceutical uptake just here in the dorsal aspect of the distal tarsal bones, probably central tarsal bone. Procedure to diagnostic analgesia, our low fall point was negative. We had a marked improvement for deep branch lateral plantar nerve blocks, such that the horse switched, but was only ever 1 out of 10 left hind limb lame. And then we had a similar degree of improvement to a tarsal metatarsal joint block on a following occasion, on a subsequent day. I just want to flag lovely Laura here, who was one of my interns at Bristol. She is holding the lameness locator Equinosis Q. I really, really like this piece of equipment for looking at horses like this, especially if you're looking at them over 2 days, because it gives you a much more quantitative view of what's going on. Oh, I have a question. Sorry, I'm just going to answer Kirsty's question. So going back to the first case, Kirsty has asked whether or not there was any considered any sacroiliac joint involvement in the case of the black mare. The scintigraphy was relatively negative for sacroiliac joint change. I'm aware that scintigraphy isn't 100% for that. I think at some point in the rehabilitation process with that horse, we probably did medicate the sacroiliac joints. My memory goes a bit hazy because it all happened over lockdown as well. But now you've mentioned it, I do recall that happened, and I don't think it had any improvement in that horse. Okay, so going back to case 2, so this is our 6-year-old sports horse. This horse was deep branch lateral plantar nerve positive and a similar degree of improvement to our TMT joint. So bearing in mind that we've got that increased uptake in our tarsal joints on the scintigraphy, we then proceeded to look at our radiographs. I haven't put the full set of radiographs up here. There was a degree of distal intertarsal joint change on the right hind, which wasn't present on the left hind, and we did have a degree of sclerosis in the the plantar-lateral portion of the third metatarsal bone. Because we couldn't tease out the relative differences in the contribution of lameness in this case, we actually proceeded to MRI, and that threw out some interesting findings in this horse. So we actually have, within the fairly plantar aspect of the third tarsal bone here, we have a fairly well marginated shallow osseous cyst-like lesion, which you can see highlighted by the yellow arrows here. And that is surrounded by, I'm not sure how well it comes out, but we're surrounded by a fairly moderate region of fluid-based signal on these images and relatively moderate osseous reaction. There is also some sclerosis of the dorsal aspect of the central and third tarsal bones, and there was some fluid-based signal in there. So that to me is evidence that we've got an active tarsal bone problem, which may well fit with our our improvement to our TMT block. This horse may be worth blocking a distal intertarsal joint. It's not my favorite thing to do, I have to say, but it might just be worth directly blocking the distal intertarsal joint in this horse to see how we get on. This horse also had some evidence of thinning of the dorsal collagenous portion of the lateral lobe and some enlargement of the medial sagittal portion of the suspensory ligament. So this horse had 2 things going on. So he had mild suspensory desmopathy and moderate distal intertarsal joint pathology. I've just highlighted this contour here. This is the normal contour of the plantar aspect of the third metatarsal bone, which, given we had a little bit of sclerosis on radiographs, I was relatively surprised to see. But actually that ties back in with that recent paper out of Colorado that actually that's not very specific sometimes. Interestingly, in the left tarsus, we had a larger osseous cyst-like lesion, but this looks less reactive to me. It's got a very narrow band of sclerosis surrounding it. There doesn't seem to be the same amount of reaction. There's not the same amount of sclerosis of the dorsal portion of the bone in this region. So I thought that was less significant. So my imaging conclusions for this horse was that we had a moderately sized osseous cyst-like lesion in the right third tarsal bone, with osteopathy of the distal intertarsal joint in that region. We had mild bilateral proximal suspensory desmopathy, and also a small an osteocyst-like lesion in the left third tarsal bone, but that looks less reactive. What do we do next? I would probably block the distal intertarsal joint in this horse and just see whether or not that gave me a different response. The discussions that we had were, do we medicate the distal tarsal region and see how this horse gets on? Do we medicate plus or minus shockwave the proximal suspensory region and see what happens? Or do we do that as a staged process and medicate the distal tarsal joints and then medicate the proximal suspensory region? Do we proceed directly to an neurectomy fasciotomy, given that this horse has got some proximal suspensory desmopathy, albeit mild, and then medicate the distal tarsal joints further down the line? And I would say that oftentimes in horses that have neurectomy fasciotomy will often medicate the distal tarsal joints as part of the recovery process. And I think the two things go hand in hand. This horse was relatively recent, so I actually don't have the outcome for this horse, but it's certainly one that we discussed back and forth for a reasonable period of time, because actually there's two areas of pathology. Potentially distal tarsal joints are more significantly than the proximal suspensory region, but this horse is destined for a reasonable level of athleticism. So it's staging what we do and seeing how we manage this horse going forwards. And again, I'm personally quite conservative, so I would probably medicate the distal tarsal joints as a first line and then monitor the suspensory ligament going forward. However, I think there's you can argue that one either way. Are there any questions relating to that?
There are a couple here, Lucy. So
Okay.
One is from an anonymous attendee who has asked, when you're saying active lesion in MRI, do you mean the lesion is acute or generally has a fluid signal?
I tend to use active lesion for lesions that have fluid signal, which is probably really bad shorthand from a radiologist. But certainly I think I tend to use it to refer to lesions that have fluid signal rather than acute versus chronic. Certainly there is a reasonable amount of evidence that lameness resolves with resolution of the fluid signal, certainly in the feet. So that's kind of why I use it. But it's probably just very bad clinical radiologist shorthand, and I should be more descriptive. But certainly, and I think we do see fluid signal in horses. Sometimes it can be acute and traumatic, but sometimes it can be a consequence of fibrosis or fat necrosis within the bone, and the fluid signal then tends to persist longer. So I don't think there's a concise answer for that one.
Okay, thank you. And then another one here from Lance Redman, who has asked, if you have any experience or do you think the use of biphosphonates like OSPHOS could be useful in cases of bone or bone ligament interface injuries, like in case 1?
I'm normally relatively reticent to use bisphosphonates in these cases. Certainly if we've only got an MRI, because I don't feel with a standing MRI we have sufficient resolution to determine whether the bone ligament interface injury is an avulsion or not. And if we're dealing with an avulsion, we're dealing with a fracture. Therefore, I worry about delaying fracture healing in these cases. So I'm often reticent to use OSPHOS in these cases. And certainly I'm reticent to use bisphosphonates in forelimbs, because we see an awful lot of incomplete palmar-metacarpal fractures. So I tend to leave the OSPHOS on the shelf, if I'm totally honest, in these cases.
Okay. Kirsty Barron has a question: would you medicate with steroid and arthrimid, either together or steroid and then arthrimid a few weeks later? And just interested in the ear defenders for shockwave in the photo. It seems like a fab idea. Do you feel it lessens your ability to read what the horse is going to do, i.e. kick? That's a very good question, actually.
It is, and certainly this is quite an old photo now. Certainly if I were to be doing this now at my clinic, I'd be wearing a hat, and I'm not sure how I'd be then able to wear the ear defenders as well. So I think it's something that is always open for discussion. I'm not entirely convinced that if it's not for photos that always happens, but I think certainly I would be wearing a hat over ear defenders doing this. I'm not a shockwaving the hind limbs is an unsafe hobby at the best of times, as is sticking needles in hind limbs of horses. So I would be going with hats rather than ear protectors nowadays, but that was an older picture. I think earplugs and a hat would be my thing.
Yeah, Kirsty's just suggested that actually as well.
Yeah, I'm not sure the ear defenders would. I'm not sure the noise, listening to the horse over the sound of the shockwave machine would actually improve my reaction with these cases. But yeah, it's just an unsafe hobby, really, isn't it?
Yeah, I agree.
It's not my favourite thing to do. So I think with regards to the medication, I usually just medicate with steroid in the first instance, whether rightly or wrongly. I tend to reserve Arthramid for slightly more reticent cases, but that's just my clinical experience. And I'm not entirely sure about Arthramid in low motion joints. I know there's a relative body of evidence that are in high motion joints, and it's improving elasticity of the joint synovium, but certainly I'm not aware of any research looking at it in low motion joints, but I could be wrong because it's not something I've looked at for a while, really. But I would just go steroid straight off and see what effect it had. And I'm quite a fan of staging things if the client's timescale will permit that. And that is often the driving factor. Is actually the client wanting to do what speed the client then wants to get the horse back on the road. But I would just put some steroid probably in its TMT and DIT, depending on how brave I was feeling and how good the horse was.
Perfect. We've got one more here from Ellen Law. What is the origin of the accessory ligament of the proximal suspensory?
So that originates on the back of the fourth tarsal bone. So we do have 2 seconds. I'll just put it with me going backwards for a minute. Actually, what I'll do, escape. If we go back to this slide here at the top, start shape there. We can see, so it just originates here. It's actually quite a meaty ligament, and it's one of those things that when you start looking for it, you do see it a little bit more often, and it just courses distally down to blend with the suspensory ligament on the lateral aspect. There is publications that report significant pathology in that region, and certainly there is a school of thought that horses that block partially to the proximal aspect of the, so partially to the proximal metatarsal bone or fully to the tibial perineal, perhaps have some pathology in there. And there is a case study of about 12 cases of horses that had confirmed pathology in that region. So certainly it's something that we see more in MRI than ultrasonography, because often we don't ultrasound that far proximally, but it's certainly something that's worth bearing in mind if your horse isn't quite blocking as you would expect.
Great. Well, thank you very much. We'll just leave the question and answer panel open for a couple more minutes, just in case anyone has any last minute thoughts. But thank you all so much for attending, and I'm sure you found that very interesting and informative. There'll be, I believe, soon after the webinar, whether it'll be later on today or first thing on Monday, I'll send you out an email with links to rewatch the not only this one, but the 2 previous winter webinars that we've done. And please do follow us on social media so you can be kept up to date with any further educational material that we're releasing. And we've got another webinar series in the pipeline, so certainly watch this space. Perfect. Well, I think that's probably enough time for questions. And thanks, as I said, thanks all so much for attending, and have a good rest of your Friday and a great weekend. We hope to see you all soon. Bye-bye.